hear from John Maher, Editor-in-Chief, Journal of Ethics in Mental Health, Psychiatrist, academic work specialized in medical ethics with a focus on competency issues. Mr. Maher?
Thank you very much. Madam Chair, honorable senators, I'm grateful for the invitation. Canada offers MAiD, but not universal palliative care, disability supports, or mental health care. Do we congratulate ourselves for our compassion in giving people an easier way to die while depriving them of the resources they need to live? How can this legislation be justified while Canadians' health rights are ignored and unprotected? Is this what free choice looks like in Canada? I studied for 9 years to become a medical ethicist and 9 more years to become a psychiatrist. I've been a doctor for 26 years. I worked for 6 years in childhood cancer and 4 years in adult palliative care. I've helped hundreds of people die, and I know what good palliative care is. For the past 18 years, I have subspecialized within psychiatry and have treated only people with the most severe and persistent mental illness. 150 of the 5,000 psychiatrists in Canada do this type of work. I am currently president of the association representing the 80 ACT teams in Ontario who care for the sickest and most vulnerable. As an association, we oppose MAiD for mental illness. Clinical relationships are already being profoundly undermined. My patients are saying, why try to recover when MAiD is coming and I'm going to be able to choose death? Some of my patients keep asking for MAiD while they're actually getting better but can't recognize it yet. Some say MAiD is morally acceptable because the law and a doctor says it is, and it comes with all the idealized trappings of medical comfort, along with the relief of guilt that often comes with suicide. Those who claim that suicide is impulsive and violent, while MAiD is well thought out, peaceful, and dignified, are arbitrarily redefining what suicide is outside of a terminal context. Social engineering always begins with language engineering. Suicide is taking steps to cause your own death, whatever the steps. Tragically, I have had patients who have killed themselves in well thought out and peaceful ways. 75% of people thoughtfully plan their own suicides. The characterization of all suicides as compelled, impulsive, and violent is factually wrong, perpetuates media stereotypes, and is stigmatizing. And to be clear, the American Association of Suicidology does not support the claim that MAiD is not suicide, except in the context of terminal illness. Terminal illness means sure death and no hope. Mental illness means no death and sustaining hope. Profoundly different states of being. Saying the two are the same for purposes of assisted death is twisting logic in the service of ideology. With the reasonably foreseeable death criterion removed, the use of the irremediability criterion is being changed in practice from definitely irremediable to possibly irremediable. Is possibly good enough when what is at stake is not 6 months, but 60 years? The applicable moral maxim is, when in doubt, don't do it. Determining whether a particular psychiatric disease is irremediable is impossible. People recover after 2 years and after 15 years. I repeatedly have psychiatrists refer patients to me where I am told they will never get better, and yet they all have improved symptom control and reduced suffering when they finally get intensive care. Inadequate care causes remediable illnesses to appear irremediable. If symptoms can't be fully controlled with good treatment, suffering can always be reduced with natural adaptation, learned coping skills, the alleviation of poverty and loneliness, and the comfort of meaningful relationships. Shared suffering is reduced suffering. Of the 100% of Canadians who attempt suicide, only 23% will try again, and only 7% complete suicide. Most suicidal thinking is ambivalent. We must not have legislation that will lead people to death who otherwise would have healed or coped. Offering an easier path to suicide is an ethically indefensible inducement. You can't offer a sanitized gun in a white coat. Opportunity begets action. Offering suicide because effective treatment is refused or unavailable is also indefensible. Death versus no treatment is not an autonomous choice, and only 1 in 3 get help as it is. By analogy, psychiatric outpatient care is like this for thousands of people in Ontario. Say you're in a car accident and you have quadriplegia and you're left in bed for years. You're fed, get painkillers sometimes, but no rehab, no aids to live, no social connection. Any surprise that you might be suicidal? Quality of life research puts the impact of schizophrenia on exact par with quadriplegia, and it's well within our power to help, but we need resources. As we speak, 6,000 people in Ontario are waiting up to 5 years to get the specialty care my team provides. In the meantime, they are in and out of hospital, getting Band-Aids on deep wounds. These are degenerative diseases. It's like being diagnosed with a growing brain tumor and having to wait years for chemo while you get sicker and sicker. This is systemic stigmatization and discrimination. Most Canadians are unaware of this artificially pressured legislative push, and only about 10% of psychiatrists have weighed in. My colleagues are shocked to hear death could be offered without the requirement that at least all standard treatments have been tried. They have absolutely no doubt that patients who would have gotten better will die if mental illness is not excluded in C7. Research shows that if 100 psychiatrists assess a person with uncertain decisional capacity, 35 will have one opinion and 65 will have another. Different psychiatrists have different skill sets and levels of experience. They also have biases like everyone else. As in the Benelux countries, if legalized here, there will be psychiatrists who become the super suicide helpers. Patients will doctor shop until dead. When the parents of a young woman recently asked me if I was going to help their daughter get better or kill her, the moral perversion of all of this couldn't have been clearer to me. Please, senators, in your wisdom, be steadfast in protecting people with mental illness who need help living, not dying, my patients among them. Merci.